All right. Well, today's topic is neurocognitive disorder. Um, just remember, neurocognitive disorder, generally speaking, is the disorder of elderly patients, elderly clients, if you will. It is different from neurodevelopmental disorder, which is a primarily the symptoms are, as a early onset, like in children, if you will. So this is not a neurodevelopmental disorder, it's neurocognitive. And you will see that most of the time the presentations are going to be in elderly clients. Even though you can have neurocognitive disorder at a young age, though. Just remember that part, please. All right. Um, so what is this disorder has to do with? Well, it involves structural or functional disturbances of the brain. Um, it may lead to impairments in memory or abstract thinking or judgment. We will talk about this as a domains in a few minutes or so. And it is rather acquired rather than developmental disorder. We just talked about that. Neurodevelopmental disorders are different than neurocognitive. Now, back in the days, all the way up until DSM-4, we would call this as like a dementia disorder, right? Now, the term dementia has been replaced by the term neurocognitive syndrome in DSM-5. The reason behind that was, well, generally speaking, when we say dementia, we really think of elderly client with Alzheimer dementia, right? But we know that you can have dementia type of symptoms, we'll call them neurocognitive syndrome, can be present in a younger population due to something else than Alzheimer, such as maybe traumatic brain injury, maybe some infection like HIV can cause it, or some other things, right? Um, so the term has been replaced. However, it is still acceptable in the clinical setting to continue to use the term dementia. There's ICD-10 code for dementia, so we can still say dementia secondary to Alzheimer or vascular dementia. But just remember that DSM-5 actually talks about a neurocognitive syndrome. Now, you can divide neurocognitive syndrome into three categories. Number one is a delirium. We must rule this out. We'll talk about this in a few minutes. And second would be major neurocognitive syndrome, and then number three is mild neurocognitive syndrome subtypes. We'll talk about subtypes in a few minutes, but just remember, subtypes are the same for mild and major. They do not change. However, the presentation, the criteria, um, as far as what type of impact these subtypes have on the client will decide if it's a mild or major. Needless to say, mild is going to have almost no or very minimum impact, versus a major impact on the ADLs will be classified as a major neurocognitive syndrome. All right. So talking about those subtypes, what are they? Well, the first one is Alzheimer's disease. Then you have a vascular. So as I said, I'm going to use the term dementia and neurocognitive interchangeably. So if somebody asks you what is the most common cause of dementia, especially in elderly clients, well, the answer is, most of the time the answer is going to be, well, Alzheimer's disease. That remains the number one cause. Second cause is vascular. So patient may have a stroke. So when you have sudden change, we did the MRI, there will be evidence of some kind of brain bleed and so forth. So that would be a second cause. um, Now the third cause is actually a combination of the third most common cause, at least, would be a combination of Alzheimer's disease and vascular. So that's kind of like a trick question. But talking about subtypes, the third subtype would be a Lewy body subtype. Now, what is that? Well, you have a client who has progressive cognitive impairment with some memory and learning problems, but this client is also giving you a presentation of some kind of a hallucination, like maybe visual hallucination, or maybe delusion. A client is delusional. Sometimes you may see some autonomic dysfunction, if you will, like orthostatic hypotension. The patient had a fall, and due to that, maybe. And then another hallmark sign would be some Parkinson symptom presentation with Lewy body subtype. And then the fourth subtype would be Parkinson disease. Then you may have a frontotemporal subtype. This type of dementia is more common in younger clients, younger than 65 years. So it's, of course, this is also going to be a gradual onset, and then they may have aphasia. That is usually a primary progressive aphasia. We believe that this is a genetic disorder, chromosome number 17. Okay, so another subtype would be traumatic brain injury. Rule that out. Of course, we would need some images for that. HIV infection is another subtype, or maybe some kind of substance use. Any maybe cocaine or whatever the cause is. All right, alcohol. Alcohol can use that as well. We have already talked about alcohol syndrome, where we talked about Wernicke encephalopathy and Korsakoff disease. So make sure you review that as well, please. And then another one is Huntington disease. Well, Huntington disease is very interesting. It's a neuropsychiatric disorder with autosomal dominant inheritance. So the presentation is going to be the client has a family history. Maybe client has it's documented that a father had or passed away perhaps with Huntington disease at a very young age. So this your client is going to be young. Usually symptoms are present in early 30s or maybe in 40s. It is not that common for these clients to misdiagnose in the beginning for other psychiatric disorders, maybe like a bipolar or maybe schizophrenia and so forth, because the symptoms do overlap, especially in the beginning. We believe this has to do with the decreased level of acetylcholine. It is genetic. We talked about that defective gene in chromosome number 4. Very rare, but very poor prognosis. The clients usually well, they don't do well, and then death occur within 10 to 15 years of onset. And these clients are going to give you all the symptoms of like a dementia and so forth, but on top of that, and they are going to have a difficulty with movement, maybe a difficulty with the gait, like ataxia, a difficulty with the speech, dysarthria, and so forth. So it's very, very sad subtype, if you will. And then prion disease. This has to do with abnormal like a protein. More specifically, well, there are many types, but the example that we have is CJD, where you have a client again early onset. It's very quick. It's rare, but very all of a sudden the client has presentation, and it's rapid presentation. The clients are young. There's no treatment. It's rare, but it's untreatable. And then you can have neurocognitive syndrome due to some other medical conditions. So maybe some kind of infection, maybe subdural hematoma, some maybe I don't know, respiratory issues, pulmonary disorders, maybe metabolic issues. Sometimes B12 deficiencies, so nutritional, or some other rare like a Wilson disease, and so list is long. So always rule out other things, of course. And you may have a multiple etiologies, so that's another subtype. And then sometimes we don't know the etiology, so that would be unspecified. Again, most common is Alzheimer, and second most common is a vascular. Third most common would be a combination of 1 and 2. And then history is so important, right? If you have evidence of HIV, evidence of traumatic brain injury, and then so this will require, if you have a strong family history, then we need to do genetic testing for this. All right. Next, we will talk about 6 cognitive domains. In DSM-5, these domains are listed as a criteria. They talk about these domains to use as a criteria for either mild or major neurocognitive disorder. So depending on the symptoms, we will decide if the client has a mild or major disorder. So the first one on the list is complex attention. Well, complex attention can be further, subdivided either as a sustained attention, divided attention, selective attention, and processing speed. So in other words, depending on the symptoms and the presentation, we can decide what criteria they're meeting. So when we interview the client or the family, and then we ask questions such as, do they have any difficulty if they have multiple stimuli in the background? For example, a television is on, or radio, and are they able to carry out their conversation or not? Are they able to do 2 tasks at the same time within that time frame, and so forth. Anyways, so what is their overall attention? Second is executive function. So this can be subdivided as either planning, decision making, working memory, responding to feedback, and so forth. So are they able to plan things? Decision making, that's straightforward. Working memory, can they add up a list of numbers or repeat a series of numbers or words backward? We have a few tests that we can pretty much give on at the bedside, if you will, to get the overall sense of these domains. Most of the tests, like mini mental exam or MOCA, slums, and so forth, we ask these questions, and then we continue to have a conversation. For example, we'll say, if I give you 3 words, just remember those 3 words, a pen, bed, or tie. And then we continue to have a conversation, and then after a few minutes or so, what was those 3 words? Can you recall those words? And then one of the pretty much in all of the major the test that we give, we'll ask them to draw a clock. So pretty much what we are doing is we're testing their cognitive domains at that time. So the third one is on the list is learning and memory. Pretty straightforward. Are they able to repeat, or do they have a difficulty recalling those events, and so forth? Ability to repeat a list of words or digits. Language, again, it can be further subdivided as expressive language, including like naming, fluency, and grammar, and so forth, and receptive language. So a client who has a significant impact in this domain, they will forget the proper names, if you will, sometimes the names of the family members. So they will they would prefer to call someone by using pronouns, he, she, they, and so forth, instead of names. Or maybe they're looking for a remote control or a pen, and they'll say, oh, give me that thing, the thing that we use to turn this thing on. So they're looking for a remote control or whatever. So that would be a language. And then the number 5 is perceptual motor ability. This is when they may have a difficulty with the previously familiar activities, a tool that they are familiar with. They know how to use that tool, and now they're struggling. It could be anything, how to make a sandwich, how to cook, whatever the deal is, or how to drive. So any task that they have already mastered. Remember, that's the thing about neurocognitive disorders, that a client has already mastered that domain or that task, which is different from neurodevelopmental disorders, because the clients, they're unable to master that, right? They're struggling with it. So the neurodevelopmental issues, the onset is early age, right? Early onset, and this is late onset. So there's a deficit here, but at one point they were able to. For example, if you are never able to draw a clock and you're not able to draw right now, then the test is invalid. So at one point, a client was able to draw or able to subtract. That's why it's so important to really keep one thing in mind, is their education level, or their primary language. If you're testing somebody with an English grammar, or sentence structure, or can you spell this word for me, but if English is not their primary language and they were never able to spell that word with using English alphabet, so the test itself is invalid. Yeah. All right. So that's number 5. Number 6 is social cognition. Well, social cognition has to do with the fact that, are they able to um, pretty much, what is their overall behavior within the social norms, if you will. As a society, we have certain rules and regulation how we behave. What is a standard? So are they out of that range, if you will? How do they dress up? How's their overall behavior in terms of sensitive issues like a religion, or politics, and sexual topics, and so forth. So anyways, what is their overall range of that social cognition? So that is number 6. Okay, so we're going to start with the first one. Remember, there were 3 types of neurocognitive disorder. The first one was the delirium. So we'll start with that. Well, delirium is, by definition, is almost always acute. So it's because it is acute, it's reversible, and usually the clients are in a hospital, setting, usually elderly patients, and it's almost always it's a medical emergency. All of a sudden, you have a client with ultra mental status, not making sense, confused. Do not diagnose that patient with dementia, Alzheimer. Think of a delirium. Try to find out the cause and treat, because it is reversible. What are some like etiology for this? How do you remember that mnemonic for assessing delirium? Well, rule out any medication. Is there any medication that can cause that? Maybe anticholinergic medications, or either over-the-counter prescription, narcotics, whatever. Any electrolyte imbalance, look at their sodium level and so forth, right? So do a complete workup. Low oxygen saturation, that can cause it, right? Infection can cause it, UTI, and so sepsis. Reduced sensory input, intracranial, urinary, UTIs or retention. Or a myocardial. So the point here is it's multifactorial. Do a complete workup and see what the target is. Is it an infection coming from the urine, or is it a respiratory infections? What is it? Is it alcohol is the cause? So rule that out. And hypoglycemia can cause that, right? Severe anemia can cause delirium. Anything. So here, we already talked about that. Infections can cause that. withdrawal. Maybe a client was taking benzodiazepine, and then maybe the client is going through withdrawal. That can cause delirium confusion. Could be acute metabolic issues, trauma, hypoxia can cause it, deficiency of B12, folate, thiamine. So what is the presentation? Well, all of a sudden there's a change in the mental status, and this alternation in level of consciousness. Family will report abrupt personality change. So grandma was fine yesterday. When I saw her for dinner this morning, I have noticed significant changes. That cannot be Alzheimer, right? Because Alzheimer dementia is progressive. Disorientation, anxiety, client is very restless, agitation, poor memory. Client may have a delusional thinking, so psychosis may be present, hallucinations. Okay, so we talked about that. It's a medical emergency. Treat the underlying cause. Same thing, we talked about that over and over. Okay, so the second part is the dementia, which is neurocognitive disorder. Second part, right? So we already talked about dementia means dementation, no change in the consciousness. So it's not acute altered mental status, right? It's a very gradual, unlike delirium. So the client is losing, intellectual function, problem solving, usually start with a loss of recent memory, and then the symptoms continue. So these are your part of like a domains that we talked about. Here is a picture or cartoon of a healthy brain. Here's a mild Alzheimer and severe. Look at the gap here. Look at this part with, look how much tissue this patient has lost, and then even here, compare that with this, compare the middle gap, even gap between this point and this point. Look at that versus this. So here's a severe. These are the stages of Alzheimer. And the first stage, client appears to be normal. They're able to cover up their symptoms are so mild, they're able to cover them up very quickly. They'll say, oh, I forgot, and then usually family member don't notice either. But here at stage 2, they forget certain things, but otherwise the function is normal, and they're able to hide all the way over here until stage 3. This is where the family becomes aware that something is wrong with the grandpa or grandma. And it's honestly, by the time they come to us, they are maybe at least in stage 3, if not 4, by the time they ask for help or the family has convinced them to see the provider. This is where they find difficulty to travel and can no longer manage their own ADLs or own affairs and so forth. This is where they really, most of the nursing home clients that I see are at stage 5, at least at stage 5, where they need help with ADLs and so forth. And as we know that symptoms progress, it's a progressive disorder. Yeah, they become incontinent here, total dependent on feeding and so forth. This is where they may be incontinence. Some clients in the beginning, they're able to go to the bathroom. They can call for help or so, but they may need help with like a showering and some other, to write a check and to handle their finances and so forth. So how do we do general assessment? Well, the main thing is detail, very detailed history. And then see if we can put them into, identify them, what stage are they in based on the history they are providing or the family members are providing or what you observed. So remember, they always they will use some defense mechanism to maintain their self-esteem. They will try their best to hide their symptoms. It has to do with their ego, right? We don't want people to think that we are weak, right? And they may be in denial. Confabulation, they make up stories to cover those gaps, if you will. It's not the same thing as a lying. They're not literally lying. They may come across that way, but this, again, is a part of their maintaining their self-esteem. So you will see these symptoms: memory impairment, disturbance in executive functioning, and so forth. We talked about these things: aphasia, loss of language; apraxia, loss of purposeful movement; agnosia, they cannot recognize common objects, toothpaste, or a notebook. What do I do with that? um, and then sundowning is one of the late presentation, if you will. Okay. So what diagnostic test we have? Well, there's no specific test, as we know. We try to rule out everything first, as much as possible, and start with like a CBC and UA, and see if we have any reversible cause of that confusion. TSH, B12, brain images. Sometimes we can get old images from the hospital, like MRI and so forth, and see if there's any evidence of prior stroke or anything like that. All right. Then there are some exams that we can do at on the bedside, if you will, and the three common ones that at least I do: mini mental state examination, MMSE, and Montreal Cognitive Assessment, MOCA, and BIMS, brief interview for mental status, and then SLUMS, St. Louis University mental status. With the exception of a BIMS, these three, MMSE, MOCA, and SLUMS, we score them, up to 30 points. That's the max, and less than 25 suggest impairment. When you have a client, getting 15 to 20 points out of 30, that usually indicate, almost always, it's a significant impairment, if you will. BIM's highest score is 15. Any number above, in my opinion, any number above 12 is a good number. 13 is a good number. And when the client has like a single digit number, like a 9, 10, 7, 8, we intervene, and then we give we start a treatment. You have access to these scales. I have uploaded a PDF file. Make sure you please take a look at it. There will be a question from these exams. And then the purpose is, again, to diagnose and then see if we can stage them. When they take these exams, it doesn't give you stages. It gives you the score, and then it's like a mild, moderate, severe. But then the stages also, you have to interview the patient and see where they stand. So what is the etiology behind it? Well, we really don't know, but we believe in acetylcholine deficiency. We believe that decreased level of acetylcholine and some other brain neurotransmitter can cause. Remember, the function of acetylcholine is to promote memory formation, sensory response, rest and sleep. So a low level of decreased level of acetylcholine has been associated with Alzheimer's disease. These are the risk factors. So treatment, well, there's no cure for Alzheimer's disease or dementia. And we offer some drugs to modify the disease or slow down the progression. There's two approaches to that. One is a cholinesterase inhibitor, and then you have an NMD receptor and methyldiasparate receptors. Let's talk about both of them one at a time. We'll start with the cholinesterase inhibitor first. So remember, I said that low level of acetylcholine can cause Alzheimer. So when you have, if this is your presynaptic neuron, and then here's some vesicle that carries neurotransmitter, So let's say that here comes acetylcholine from that neurotransmitter. Here comes acetylcholine in the, here's a presynaptic neuron, and then here's a post. So the space between pre and post is synaptic cleft, right? So acetylcholine is present in the synaptic cleft. Here are the receptors, like a muscarinic receptor, nicotine, right? Those are the receptors for acetylcholine. So let's say these are the muscarinic receptors. So when acetylcholine will bind at these receptors, once the activity is over, two things will happen to this neurotransmitter. It will go back so that it will reabsorb, so that we can reuse that, and we call that reuptake, right? Reuptake. That's one thing that will happen. The second thing is there are some enzymes that will destroy acetylcholine. So we call that degradation. So degradation of the enzyme occurs by the enzyme that will destroy acetylcholine. So we have a client, let's say 85-year-old male with dementia secondary to Alzheimer's disease. So this client is going to have a low level of acetylcholine to begin with, right? So on top of that, this enzyme is destroying acetylcholine here. So what we can do is, so the name of this enzyme is cholinesterase. That's the name of this enzyme that is destroying acetylcholine. You know it's an enzyme because it ends with ACE. So what we can do is we can give a drug that will inhibit the enzyme. So we call that a cholinesterase inhibitor. This drug will inhibit the enzyme that was destroying our neurotransmitter acetylcholine. Once you inhibit the enzyme, the levels of acetylcholine will increase. Pretty much what happened is we are actually making acetylcholine available a little bit longer, so we will increase the availability, or it will stay in the synaptic cleft for longer duration, if you will. Yeah, and sometimes that's all you need to make some improvement in the symptoms. So the so here's the enzyme acetylcholinesterase. That's the name of the enzyme that we are going to block. So examples are donepezil, that very common drug. Aricept is a brand name. Sometimes we use Exelon as well, but my go-to drug is pretty much Aricept. Donepezil. So donepezil is cholinesterase inhibitor. In other words, it will inhibit the enzyme called acetylcholinesterase. By doing so, you will have increased level of acetylcholine. Okay, and that's what we wanted. So that's one way of treating the symptoms. The side effect, to be honest with you, most of the clients, they tolerate the medication very well. Once in a while, a client may give you some GI side effect, but usually medication is handled very well, in my opinion. Okay, so the second approach is there is a theory that glutamate levels are high in clients with dementia. So a drug called memantine. So remember, glutamate is another transmitter. So memantine will decrease the glutamate level. So again, you have, here's the cell, and here glutamate comes in and then open that calcium channel here. So the medication will block and decrease the level of glutamate. What we are trying to do here is, again, manage the symptoms. This is not a treatment for Alzheimer. Most of the time we start a client on the donepezil or Aricept first, and then we add memantine. which is Namenda. Side effects are again confusion, agitation, um, which, to be honest with you, are symptoms of dementia as well. So sometimes it's very difficult to find out if drug is causing agitation, confusion, or restless, or is it the disease itself. Now, we have a combination drug called Nemzaric, which is a combination of a memantine and donepezil. Remember, this is your Aricept, and then here's your Namenda. So combination is Nemzaric. I usually start with Aricept, and when you have a client who well, so if I'm going to assess this client, let's say in 6 months, 3 months, or quarterly, whatever, and then if there's a time for me to add Namenda, and I will do it, eventually I will just put that client on Nemzaric instead of having the client to take 2 pills. There's another study that was done. There's evidence that vitamin E, about 2000 international units a day, may help with some mild to moderate symptoms improvement. So something to think of. SSRI, yeah, more specifically citalopram, has been shown to decrease that agitation that I was talking about earlier, anxiety. Remember, clients as the symptoms progress with the dementia, the family members are going to report some, agitation and sundowning and so forth. So at that time, it's worth adding SSRI to calm down the patient instead of doing antipsychotic or benzodiazepine. Be very careful. I have seen this a lot in a primary practice um, where you have a client on maybe Seroquel or sometimes even Haldol or first or second generation antipsychotic medication and so forth. We have to be very careful with that because antipsychotic medication, they do carry black box warning where they're not approved for dementia related psychosis. So there's actually increased mortality risk, especially in the elderly patient who are on these antipsychotic medication. So be very careful. I know that people use Seroquel a lot to sleep, especially for insomnia, especially in dementia patient, but try to avoid as much as possible. And same thing, avoid benzodiazepine. And then if you have to use antipsychotic, let's say the client has some psychosis, maybe some hallucination going on, and so use the low dose, but then make sure you document very carefully that you're aware, and then this was discussed with the family and they're also aware, and then perhaps benefit out of the risk. And then at this time, I don't know, maybe patient goal is comfort care, you talk about palliative care, hospice care, so think about those things before you start using antipsychotic in these settings. And then maybe do some like a group therapy, show them you know uh, pictures or their favorite music and bring those memories back. People do connect that way to improve your social skills and improve your mood and morale and so forth. So refer for that. And they do teach the family member regarding regular predictable daily schedule, perhaps a referral for care centers so that a family can also get some rest. It is very difficult to manage these clients, and even in nursing homes, it's very can be very overwhelming experience. And always remember the goal, and let the family know that the goal is not to treat Alzheimer dementia. It is to improve quality of life by maybe decreasing those symptoms, minimizing by improving cognitive function. But at this time, there's no treatment. I think they're talking about a vaccine, but we are not there yet at all. But anyways, at this time, the goal is really a quality overall goal is to, if the patient is able to maintain ADLs as much as possible, and safety and comfort. And that's all I had. As long if you have, as usual, if you have any questions, concerns, always please email me or contact me. And thank you so much. I appreciate it.